All right, good afternoon, everyone. First, I'd like to thank the organizers for the kind invitation to speak at this wonderful symposium. As mentioned, I'm just about a 15-minute drive away at Providence Cancer Institute at the Earle A. Chiles Research Institute. Today, I'd like to tell you a little bit about TILs, which stands for Tumor Infiltrating Lymphocytes, and cell therapy for cholangiocarcinoma. Here are my disclosures. So I think Dr. Earle did a really good job kind of setting me up here. So, but I do just want to give a brief kind of description of what adoptive cell therapy so that we're all on the same page. So it's really a type of immunotherapy that where immune cells, most commonly T cells, type of white blood cell in our body, are removed from a patient, grown and manipulated in the lab, and reintroduced back into the patient. And the rationale behind this approach is that infusion of a large number of tumor-reactive T cells will be able to overwhelm and eradicate the tumors. As Dr. Earle mentioned, there are really two major types of adoptive cell therapy. The main focus of my talk is really on the tumor-infiltrating lymphocytes, or TILs, as I'll call them. Dr. Earle mentioned about gene engineering, and that's the second major type. And T cells derive from the peripheral blood of patients, but then are genetically modified to express receptors that target the tumor. And again, this comes in two different flavors, T cell receptors, or TCRs, and chimeric antigen receptors, which I won't go into and which Dr. Earle already had mentioned. So adoptive cell therapy using TILs was really pioneered by Dr. Steve Rosenberg, who you've mentioned that name, you've heard this name a few times today, at the NCI. And this was developed many decades ago. And it's highlighted by this cartoon here. So a patient comes into the clinic, a tumor is excised surgically. That tumor is then taken into the lab, minced up into small fragments. Within tumors, there are these white blood cells called TILs, tumor-infiltrating lymphocytes, and they're cultured in high-dose interleukin-2, or IL-2, which is a T cell growth factor. So what this does is that over the course of 2 or 3 weeks, you can get thousands of cells here. They'll proliferate, expand to millions of cells. And then some of these cells are selected for further expansion, what we call a rapid expansion. And this is a process by which millions of cells become billions of cells, and we can get 10 to even more than 100 billion cells. And these billions of T cells are then reinfused back into the patient who's been lymphodepleted. Again, Dr. Earle mentioned that melanoma has really been a poster child for immunotherapy, and that's where TIL therapy has really been explored. And we learned a few lessons from TIL therapy in melanoma. And that's really highlighted in the next few slides. So the first, and I think most important, is that TIL therapy can be curative. So in patients with metastatic disease, widely metastatic, the infusion of TIL can eradicate the last cancer cell. The overall response rate is about 50% in metastatic melanoma, but the complete durable response rates, these long-term cures, could be in the 20 to 25% range for metastatic melanoma. And so there are patients out, maybe 30 years now from Dr. Rosenberg's day that are still alive without evidence of disease. These sorts of data led to the FDA approval of TIL therapy for metastatic melanoma in 2024, just last year. And this is kind of, just want to highlight what this kind of looks like. So this is a patient treated at the NCI. The patient was 29 years old with metastatic melanoma under the skin that had spread to lymph nodes. This is a picture of the one tumor on his neck, shoulder area that's before treatment. And then actually just 12 days later, you can see it substantially shrink, right? So this is after transfer of billions of these TIL cells. And this is one of the patients that had these durable long-term responses. I just want to highlight this, that when you get the right T cells, enough T cells, this is the power of T cells and what they can do to tumors. And so another lesson that we learned in the setting of melanoma is that TIL recognizing mutations, or neoantigens, I'm going to use those two terms interchangeably, likely played a major role in the clinical responses. And so what do I mean by that statement? Really that in patients that were infused with these TIL, when we did retrospective studies, kind of studying what we gave the patients, we could always find T cells that recognized mutations expressed by the patient's cancer. So, and what I mean by mutations and neoantigens, so I'm just highlighting in this cartoon here, the major hallmark of cancer cells is that they're different than normal cells. And the difference is really in the DNA. So there are changes in the DNA of cancer cells. These are called mutations. Some of these mutations can be then translated into a protein. And there could be a change in that protein because of that one mutation. So you have a mutated gene, that mutation gets translated into a mutated protein. It could be just one amino acid, right? Just one amino acid change. If that one amino acid change is then presented on this tumor cell, on this something called HLA molecule, then it is now potentially foreign, right? Because this is not something that's normally expressed by the person's body. And so in every patient, there are billions of T cells, each with different T cell receptors, and there may be some that now recognize this mutation or neoantigen. And so this is what I mean by neoantigen reactive T cell or mutation reactive T cell. And so during my time at the NCI with Dr. Rosenberg, we really asked the question, can we harness this mutation reactive T cell response to treat patients with metastatic epithelial cancers? And so I'm really going to highlight this by going through some of the details of Melinda Bachini's treatment. So you've heard a little bit about that from Melinda and also Dr. Earle, but I'll give you a little bit more detail in what we actually did. So Melinda was really the first patient in the world with epithelial cancer to be treated with TILs, targeting a unique mutation. You've heard this background. So we generated TIL for Melinda, as I described in the first cartoon. We generated 42.4 billion cells, and we followed that up with 4 high doses of interleukin-2. Retrospectively, we found that she had received about 25% of the TIL were targeting a unique mutation in Earle B2IP, only expressed by Melinda's cancer, so no one else has this mutation. And here's just a lung CT prior to therapy and then after therapy. You can see that after infusion of TIL, these lesions have shrank. And then if we look in her liver, we can see the similar trend of shrinkage of these liver lesions after cell infusion. So when we kind of graph out her tumor burden, so this on this graph here, this is tumor burden on the y-axis and then time relative to cell transfer here. You can see that tumors were progressing, lung and liver tumors, cell infusion, and then you can see that the tumors decreased and never reached the 30%, which is the clinical criteria for a responder. So I think she was maybe 28% or 29%, but she certainly had a disease stabilization for about a year. But as you can see that her tumors began to take off again, her lung tumors did. So we asked the question, can we do better? And so we went back to that hypothesis of mutation-reactive T cells, right? So she received 25% mutation-reactive T cells. We thought, can we give her a better treatment? The first treatment was made up of 5 different T cell cultures. And so when we looked at each T cell culture, we found that one was really highly enriched in the mutation-reactive T cells. So we selected that for retreatment. After expansion, 95% of all the T cells in the infusion product were reactive to the mutation, and we generated more cells, so 126 billion cells instead of the 42 billion cells. And then we infused, those cells, and you can see here in her lung CT, the bulky disease in the lung. This is 2 years later after infusion. You can see that the lesions have shrank substantially. Some had disappeared. And so, again, this is a similar graph as I showed you before, just looking at both her treatments, looking at the tumor burden over time after both her treatments. This is the first treatment here. You see stabilization disease. Tumors took off, and you can see that they were getting quite large. And then we infused the second round with a highly enriched population. You can see this kind of deeper and longer regression of her metastatic disease. But you can see here, they're starting to come back up again. So we really asked the questions, why did some of the tumors progress? And can we give her another effective treatment? So the next slide is maybe the most busy slide that I'm going to show you in my presentation here. But what this graph depicts is the mutation-reactive T cell frequency in Melinda, in the blood, which is highlighted in red circles, in the infusion products, which are the bars, and then the solid, or the symbols by themselves are actually in the tumor. So again, these are frequency of the mutation-reactive T cells in Melinda. You can see that the first infusion product was about 25%, and then after infusion in the blood, they stuck around, but then started to dwindle. Progressing lesions were resected. You can see that they're actually there between 1 to 10%, so they made it to the tumor. And then here you can see that second infusion product is 95% after infusion. You can see in the blood we get high-level persistence. So this is about 3 years after infusion. Nearly 3% of all her circulating T cells in her body were reactive against the mutation. When we look at the progressing lesions at the same time, we see about 50% of all the T cells within the tumor are mutation reactive. So, the fact that the tumors are progressing, it's not because the T cells are not there. It's not because the mutation reactive T cells are not there. They're there at very high levels in the blood in the tumor. So something else is going on. So what we did was then we took these tumors here that were resected and we analyzed them. So maybe these T cells are being shut down. You've heard the term PD-1, PD-L1 today in the talk. Those are immune checkpoints on T cells. So we looked at that. So when we looked at the T cells in the tumor, this axis, V beta 22, is just looking at the mutation reactive T cells. So anything that stains here is mutation reactive. PD-1, again, is an immune checkpoint. So again, if they're expressing this marker, then the T cells could be getting shut down. You can see that the reactive cells do express higher levels of PD-1, suggesting that maybe this pathway might be active in these cells. And then what we did was we also did IHC, immunohistochemistry. So we looked at the tumor tissue. Is the ligand, is the receptor to this PD-1 found in the tumor. And you can see here, we did a stain. So PD-L1 is what binds to PD-1 and triggers a shutdown of T cells. If you see brown, then that means cells are expressing PD-L1. And I hope you can appreciate, I don't know if it shows up well, but yes, it's you see a lot of brown here. And so it turns out that a lot of the macrophages in the tumor are expressing PD-L1, which could engage with these mutation reactive cells and shut them down. And so we asked a very simple question: can we add anti-PD-1 therapy to reinvigorate these mutation reactive T cells? And that's what we did. And so we tracked 2 tumors. You can see here in the lung. So this is before PD-1 treatment, then after PD-1 treatment 3 years later. So you can see, so this one lesion has completely resolved. And this one lesion shrank and has remained stable throughout the entire course of therapy, which is actually 6 cycles of anti-PD-1. And so there was complete regression of one lesion, and the other lesion shrank and remained stable to this date, greater than 8 years after her last dose of anti-PD-1. So again, that was really an example of the potential power of mutation reactive TIL. And so Dr. Rosenberg's group has been doing this for many years now and looking at deploying this strategy, harnessing mutation reactive T cells in patients with metastatic gastrointestinal cancers. And so they published this just a few months ago in Nature Medicine, essentially summarizing their results. And so the first graph I want to show you, this is called a spider plot. And so when this strategy is deployed, trying to select the neoantigen reactive TIL and treat patients with them, there are low response rates. So 3 out of 39 patients, about 8% of patients, had a response. 1 patient with cholangio, that's Melinda. 2 patients with colorectal cancer also had a response. So you can see here in green, this is Melinda in green here. We had another patient that we treated with KRAS reactive cells at colorectal. This is in blue. And another patient had a response. But there are only 3 patients out of 39, so 8%. So given what I've kind of told you about PD-1 and maybe how that could be helpful for T cells, Dr. Rosenberg's group tested, well, can we enhance this therapeutic effect, right? Can we add anti-PD-1 with this mutation reactive TIL to give greater responses? And so I'm going to show you another spider plot now with the same strategy of the neoantigen mutation reactive TIL, but with anti-PD-1. And so now the clinical responses were observed in 8 out of 34, so about 24% of patients instead of 8%. 1 patient with cholangiocarcinoma, 1 with pancreas cancer, and then 6 with colorectal cancer. And you can see here. The patient with cholangiocarcinoma is the one here in green as well. And I want to show you the scans here. So this is a patient with metastatic cholangiocarcinoma. She was treated with 100 billion TIL, targeting at 3 different mutations in her tumor. And then she got IL-2 as most other patients did. And what you'll appreciate here is actually something that I actually never had seen before, a bone disease that has responded to cell therapy. So this is a bone lesion that after 9 months, you can see it's pretty much resolved. Here's a lymph node mass that's a periaortic lymph node mass that has essentially resolved. This patient actually had disease in lung, liver as well, and she had, again, a response. And at the time of the publication, she was an official partial response at 17 months post-treatment. And again, here are the other sites of disease. So that's really TIL therapy. In this particular report that Dr. Rosenberg put out, 10 patients with metastatic cholangiocarcinoma were treated with TIL, this sort of TIL, and there are 2 responders. It was Melinda and this 17-plus month response in this other patient with cholangiocarcinoma. And so what are other cell therapy strategies that we could use to target cholangio? So Dr. Earle kind of mentioned this. This is a gene engineering approach. So we take peripheral bloods from patients, engineer them to express a receptor, in this case, a T cell receptor that can target a specific antigen, we call it. And then we expand those and give those to patients. The limitation of this approach is that a single TCR can recognize only one target, one antigen, in the context of one HLA or MHC molecule. So this molecule here has to present the target. So the tumor must express the target, and the patient and the tumor must express a correct HLA molecule. But nonetheless, so our group at Providence just published this 3 years ago now, where we deployed this approach in pancreas cancer. So this is a patient with metastatic pancreas cancer, metastatic to the lung. She had KRAS G12D and also HLA-CO802. These are the 2 parameters that are important because we had T cell receptors that targeted those 2 parameters. And so we generated 14.8 billion cells in this case that were reactive against KRAS G12D, infused it. And you can see here is a CT of her chest before treatment, lung disease here with the yellow arrows. 3 to 6 months later, you can see that the disease has substantially shrank. So overall 72% reduction, partial response at 6 months. She had a response that lasted for 1 year. And so unfortunately, this patient was not cured, but this really provided the first proof of concept that this approach, taking peripheral blood cells, engineering them to express a mutation-reactive T cell receptor, could actually shrink pancreas cancer. So with that, I'd like to just conclude. The adoptive transfer of these mutation or neoantigen-reactive T cells can mediate regression of metastatic epithelial cancer, including cholangiocarcinoma. It seems like adding anti-PD-1 to this therapy can enhance the efficacy. TCR-engineered T cells targeting an oncogenic mutation, KRAS, can mediate the regression of metastatic pancreas cancer, which provides hope that this approach might be effective for cholangiocarcinoma. So you might have caught it in earlier talks, but KRAS is also mutated in a subset of cholangiocarcinomas. Adoptive T cell therapy does not work for many patients, and therefore improvements are needed. This is kind of my final slide. I'm not going to get into too many details, but I'm just highlighting some strategies here that can potentially enhance therapy, either directly enhancing the T cells themselves or just combining that therapy, giving other therapies to the patient. So things like manipulating cell manufacture conditions, so how we grow the T cells is important. We can knock out things in T cells, we can knock in things, and we can, instead of going to TIL, we can actually maybe go to the blood of patients and then pluck out the reactive cells and use those for therapy. And that's an active project we have ongoing in my lab. I'm not going to go into these potential combination approaches, but we could essentially take T cells, manufacture them better, infuse them, and then deliver other systemic therapies that might boost the activity of those T cells. So with that, I'd like to just quickly acknowledge, these acknowledgements are really, I have a cell therapy program at Providence, and it really takes a village, and so many people involved with that. I do want to put special mention to Dr. Walter Earle A, who is the founder of our institute, but recently retired. He was critical for building the team there and just pushing us in the right direction of immunotherapy and recruiting me for cell therapy. And lastly, I really want to thank the patients and their families for putting their trust in us. And that's the reason why we're here doing what we do. So with that, I'd like to thank you for your kind attention.